This conference will now be recorded.
Hi, it's Tuesday, June 23rd, 2026. Welcome to the AnCan virtual support meeting for high-risk, recurrent, and advanced prostate cancer. Happy Pride to anyone celebrating this month. It's good to see everyone here. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined by moderators Len Sierra, John Antonucci, and Rick Davis, the founder of AnCan. You'll hear us discuss medical issues, but we're just a bunch of guys. Nothing you hear is to be taken as medical advice. Sponsorship for this meeting comes in part from these companies whom we thank: Novartis, Blue Earth Diagnostics, Foundation Medicine. Anyone else climb aboard, Rick?
Sorry, I was reading something in the Foundation Medicine. Right now, we got Foundation Medicine, Telix, Novartis, and Blue Earth.
Okay, Telix is back.
I just, if you leave something, okay, I got it.
So let's begin. We have new
I
participants.
can't get it in these ears.
Whoa.
Yeah. Guys, if you're not talking, we'd really appreciate it if you mute, because otherwise it gets a little confusing for us. Please. Thank you very much.
Okay, so Billy is one who is going to be new tonight, and Rick and Bill Franklin had found someone else. Is that person here?
Currently, the person is attempting to connect through their phone. So
okay.
We'll have to see.
Provisionally here. Okay, Billy.
Right. That's not our person. That's Avery. So if Avery comes in, I expect he's new, and the person that Bill and I have been in contact with is not here.
Okay. So Billy has already joined the, usually what we do is ask questions. Billy has already joined the under 60 group and answered all these questions. So if you don't mind, Billy, I'm going to just go through it quickly.
Sure.
Billy is a tender age of 65.
55.
55.
55. Did I say 65? No.
Yes.
Sorry.
That's
Last November, he had a very slight PSA change, a small PSA of 4.1, and he was found to have, even with that low PSA, Gleason 4+5, 50% positive cores, intraductal, and 3 node metastases. He has PTEN loss. 40x proton. Billy, what is that?
I'm having a proton radiation to the prostate and pelvic lymph nodes.
Oh,
40 sessions.
Okay. Was getting Orgovyx and Abby, and switching to Eligard for QTC reasons. And his PSA is currently 0.5. So one thing that surprised us was that you're having heart issues on the Orgovyx, which had been advertised as safer for the heart than Lupron. That the class of drugs that are LHRH antagonists are as a class safer, so that you'd be better off with Firmagon or Orgovyx.
Yeah, Bill, let me comment on that, Ben. Actually, I'd like Dr. John to comment, because as a result of speaking with Billy, I ran it past Dr. John, and there is actually, I believe, a QTC warning on the Orgovyx. John, can you talk about that?
It's you know, all these drugs can let me just a little bit of background on the EKG. There's all these different points on the curve, Q, R, S, T, and the spacing between the Q wave, which is the depolarization of the ventricle when it contracts, and the T wave when it repolarizes to get ready for the next beat, can be lengthened by different drugs and different conditions. And it's a little bit risky because if it gets long enough, you can have a dangerous arrhythmia. Orgovyx, like many other drugs, can extend that QT interval. And for that reason, he's going on Eligard, which can also do that, but is, from what I gather, less likely. So he probably won't completely get out of risk of QT. It'll be monitored closely, I imagine, but it might be less risky than Orgovyx.
I have another EKG scheduled, but yeah, Dr. Belusic, my medical oncologist, mentioned that I guess there's a 5% chance of what happened to me happening. And so along my journey, I've been hitting all the, I can't hit the lotto, but I could hit all these low percentage side effects. So
side effects, yeah.
Yeah.
What is your QT interval or QTC? Do you happen to know?
I could look that up. I don't remember off
All
the top
right,
of my head.
just put it in the chat if you happen to catch it.
You know, I'm looking at this screen, and Billy's a Jimmy G lookalike. Look at that. Look at the two of them.
I made the same mistake.
Yes. So, Billy, if we call you Jimmy G, you'll know why, okay?
We got the same haircut. Yeah.
You got the same haircut, same shaped head, same. This is very interesting. Of course, Jimmy G's a celebrity. We hope you'll become a celebrity with this group as well.
Good looks only given out to the few. We're sorry. It's just the way of the world.
You know what? There is something that came out of this, which and God bless Dr. Belusic. I mean, we know he's terrific, and Dr. Jack will vouch for him, and others will vouch for him. But it is recommended, in fact, that you do this EKG, and most docs don't do it. And so maybe one of the take-home messages from this to your GU medical oncologist is, you know, should we be doing an EKG? Is that a fair statement, Dr. John?
Well, if you look at the actual prescribing directions, they don't say that it's required. They say if a person is at high risk for prolonged QT, do an EKG. You know, things like that. But I would be very comfortable with everybody heading into this type of treatment to get an EKG. So it's not required, it's not mandatory, but I kind of like the idea. And if he was my patient going on Orgovyx, I think I'd do it. Nobody ever did a cardiogram on me from my oncology team or practically anybody else that I've seen in this group.
Tomatika?
Yeah, and Dr. John, please remind me of what you would be looking for on that EKG. Yeah, can you hear me?
You know what they look like, those cardiograms? There's a Q wave, and then farther along in the cardiogram, there's a T wave. And it's the amount of time in milliseconds between the Q wave and the T wave. Now, the faster the heart is beating, the shorter the time for the entire complex. So there's such a thing as a QTC, QT interval in milliseconds corrected for the heart rate. One time, a couple of years ago, Jack and I had a little debate about which was the better measurement. So I don't really know, but that's what the QT, that's what we're looking for, Thomas.
Okay. Yeah. Before I read your email, the Heart Group email, I sort of had this attitude of a very casual switching from Permagon, which has been working for me for about 3 years, and going to Orgovyx because I don't have to drive to the hospital then. I mean, a very casual reason. Now it sounds like this is not so casual. There could be some implications depending upon my EKG.
That's right. Nobody would routinely get a cardiogram on those of us that switch from an agonist. What's a better word I could use? Anyway, from one class of drug to Orgovyx, unless we have a history of risk of arrhythmias or unless we're on another drug that can cause arrhythmias, then they should automatically get a cardiogram. Whether we should convince our doctors to grab one when we switch from Permagon to Orgovyx, I don't really know. I probably would, based on Billy's experience. They might say, "Oh, it's not necessary," but you know.
And you know, the other thing with Billy that we learned, and Billy, please correct me if I'm wrong, is that Billy doesn't have a history at all of heart issues. So it was really an alert medical oncologist who ordered the test. Is that right, Billy?
Yeah, no issues. I'm pretty active, and looking back though, I do remember like when I was playing pickleball, I could feel my heart, and I thought maybe it was just because it was getting so hot down here in South Florida. I did have one day where I came back from radiation, and I had done an enema that day, and so my electrolytes were kind of low, but I felt kind of dizzy, and so those were things that after this coming to my attention sounded like maybe it was related to the QTC. So I'm putting in the chat, Dr. John. I put in there.
482. Okay. Now
Yeah,
there is
like 3 years ago, it was 420, 437 range. So.
Okay. There is actually an internist with his hand up in the room. And in the past, I've made Alfredo promise that if he disagrees with anything I say about internal medicine, he has to correct me right away. So if you don't mind, Ben, I'd like to see what Alfredo has to say.
It hasn't happened yet that I've needed to correct John. So far, so good. I just want to say, it's funny that we're having this discussion. A lot of my work is in the economic side of healthcare. EKG is such a cheap test. Nobody should debate about it. I mean, to me as an internist, it's adequate. If the patient says, doc, I'd like an EKG. I don't care what the reason is. Great, go down the hall, get it done. Yeah. It's non-invasive. It doesn't hurt. There's no drugs. We might learn something.
The machine reads it right away too.
Yeah, nowadays, yeah. So I just wanted to throw that in, that there's really very little reason to talk yourself or your doctor out of getting an EKG. It's easy to do, readily available. We're talking, less than $50 would be changing hands from Medicare or your insurance company, whoever, to whoever's doing the EKG. So it's kind of not material. Just get it. In fact, I'm going to have a physical pretty soon, and I'm going to say, hey, we haven't gotten an EKG in a while. So that's my only comment. Sorry.
Thank you. Jim Marshall, your hand's been up.
Yeah, I get them a lot actually because I've got a strange QTC interval, and in fact I have one up now. On the report you get, it will be self-explanatory. You do not have to look at the waves. Like I've got a cardiac rate of 52, the QT interval is 464, QT corrected 431. And I don't know if you're interested in the QRS interval or the PR, but in the bottom it says abnormal. So I wasn't quite sure, and the doctors look at it and they scratch their head and say, "How do you feel?" I said, "Well, I'm here, I don't know. I think I've had it for a long time, all during the time I was on Lupron plus the Eligard, and nobody said a word."
So we'll come right back to Billy in a second so he can ask the group any questions that he has concerns about,
Sure.
since he's just recently on Doublet. But I just want to give a plug to Dr. John, first of all, because he has initiated this prostate cancer heart group that we call ProsCard. And if anybody is not on that email distribution and would like to be, then send an email to Dr. John or to me, and we'll make sure you get entered, and you'll get a regular email. Dr. John's been writing every weekend with like a tutorial and a it's very helpful. And the group has indicated that it would like to be a video group like this one. And so we're going to start meeting on the first Wednesday, the first Wednesday of every month at 6 o'clock Eastern. There may be an informal meeting next week, but I would say the official start is probably going to be in August. That is going to be open to anybody. So anybody who has a heart issue, wherever they are, in any AnCan group or from outside, we're going to make that a heart support group. And the ProsCard list will just stay like it is right now for prostate cancer men. So Billy, if you're interested in being on that list, let us know. We'll add you to the list. And then everybody who's on the list will automatically get transferred so that they receive a reminder when we get the reminders going. John, would you like to add anything to that?
Nope, nothing to add. Thank you for the announcement.
Len Sierra, your hand is up.
Thanks, Ben. Since we're talking about EKGs, I happen to be wearing right now something called a Zeo patch. Rick tells me we have 5 MDs in the group tonight, so I'm sure they're all familiar with it. But it's like having an EKG strapped to your chest 24/7. It's something I wear, applied myself. At the end of 7 days, I take it off, ship it back to the manufacturer, and they send all the data to my cardiologist. So it's very simple to do, maybe something that Billy should be doing or anybody else.
Have to apply a lot of electrodes like with a regular EKG?
No. Well, I mean, there are electrodes there, but they're kind of embedded in the tape. It's only about this big, and it's taped right to my upper chest here. Yeah. Yeah, it took like a minute to put it on.
And it stays on, you shower with it?
Yes, they said you could shower with it, and I have, but they said keep your back to the shower. So I guess they don't want it to get really wet, but if it gets a little wet, it's okay. So, it's manageable.
So the device itself is embedded in that thing that you tape to yourself.
Yeah, let's see. I usually charge to let people see my massive pec muscles. But there, can you see it?
Oh, wow.
That's it.
Yeah.
That's the whole thing. There's a little button right there. Like if, so I'm wearing it because I've been having near syncope episodes. The in-office EKG was normal. So I guess just to do a CYA, she ordered this for me to wear for a week. And anytime I get a near syncope episode or any other cardiac episode, I just press that button, and then there's a little log. You can use the app that's on your phone or paper log, and you just say, like what time of day this happened, what you were doing at the time, that sort of thing.
Great.
Used to be
David?
called a Holter monitor.
Oh, yeah. That's
Yep.
a thing that rings a bell. David Muslin, what say you?
What say me? So I had AFib years ago, and my internist had me on Eliquis, and I got sick of taking Eliquis, and he told me get an Apple Watch, and you can do an EKG on your Apple Watch 3 or 4 times a day and send it to him. So that sounds kind of crazy, but I've been doing it with an Apple Watch.
And he's satisfied with the quality of it?
Haven't sent it to him yet, but I look at it myself. It tells me if I have AFib or not, and it looks like a real EKG. You hold your little finger on the button. It's kind of crazy, but it works. And then it records on your phone, and you send it right to your doc from there. How's that for modern technology?
Jack brought it to our attention not too long ago that sometimes those devices can mistake other arrhythmias for AFib, but you're going to send the tracings to your doctor and they're going to read them anyway. So they're pretty accurate, but they actually can be fooled. My cardiologist told me to get a device also.
Yes, they can have false positives. I'm in the car driving, but I'm listening, and they do have false positives, quite a bit. Both the AliveCore and the Apple Watch.
Your hands.
Yeah, I've had a Holter monitor on a few times, and they always have multiple leads. And I read about the Zeo patch that it records heartbeat, heart monitor, not that it does an EKG. What do you see the results of that?
No, that's the way it's described in the package they send you. It's basically a portable ECG.
It's a one-lead cardiogram.
Okay.
Exactly.
It's quite accurate too. It's very accurate. I just finished wearing one for the past week. They are very accurate compared to the Apple Watch, and the Zeo patch is good.
So, and let's go back. Let's go back to Billy to clear up, because I think Avery came into the room now, so we now have a second new guy. So, hey, Billy, come back on with any queries you have, man.
Yeah, so just with the talk with the QTC, I love Dr. John's perspective. I'm assuming when I do my follow-up EKG after being on Eligard now, I'm hoping that it goes down. Is that a realistic expectation, or am I kind of stuck with this? I've definitely felt better since being on the Eligard shot. I haven't had any of those episodes where I feel anything weird cardio-wise. So
That's exactly right. We're hoping for that QTC of 482 to go down to a lower number.
okay, perfect. And from what I understand from Dr. Bulisic and talking to some other guys, it seems like with the shot, they don't really do an EKG, right? So it's not common. He was saying that he's had some people in similar situation as I that have gone to the shot and didn't have the QTC issue. So I don't know how many he's had, but it did seem like that he's kind of seen that happen a few times.
Good to
Overall,
know.
I feel really, really good. I've been getting the proton radiation for about 4 weeks now. I'm about halfway through there. I've been on the ADT for 2 months. Yeah, feeling really good. I wasn't necessarily expecting that. I don't know, pretty active, and so hopefully that's helping. But my biggest challenge right now is prep for the proton radiation. I have to have everything, when I go in the morning, my bladder has to be full, my rectum has to be clear, no gas. I'm following a pretty stringent schedule where I, try to prep. I'm eating right now to try to eat early. I'm eating a light meal, but I've been struggling with it where, I go in for the scan and things aren't where they need to be, and I have to come out and do an enema or something, I try to relieve myself naturally, or my bladder is too full or not full enough. And it's been a little bit of a struggle, but I've gotten a little better recently, and so I hope I'm on the right track. I think one of the things is I've been eating a smaller meal at night, just chicken and rice, not enough to totally satisfy me, but just, a small amount. And then, I've been able to get it going. So if anybody has been down that road that has any feedback, I'd appreciate that. And then my only other issue is, which I'm sure anybody that's been on ADT has experienced, my sex drive wasn't the highest to begin with when I started down this journey, but it's definitely dropped to kind of nothing. And so that's kind of a weird experience. And so I'm assuming for the 2 years I'm on this, I'll just have to deal with that. But if anybody has any best practices or anything to kind of deal with that, just and anything else that anybody in the group wants to share as I'm kind of starting on this journey, I'd appreciate it. But overall, I'm in great shape, thank God. So life is good.
Dr. John, what are your thoughts?
Well, I was going to ask Billy what insurance company is paying for proton treatment right now, and then we can get into the sex drive question.
Yeah. So I know when I first went to Dr. Mahal, my radiation oncologist, he said, hey, you have a lymph node that's kind of in a sensitive area, and I think we got a good case. And so I don't know if it was his ability to make a case, but I'm on United, UMR, a subsidiary of United, and they've actually been really good. So I'm on my wife's insurance. I was fortunate enough to retire from my job at 35 years a couple of years ago, and so I've been really happy with the insurance. It's been covering things. I haven't had anything denied with that. But again, I don't know how he said we had a good case, but it did seem like it was something that was kind of hit or miss. And when we got the news that they approved it, I was pretty happy with that.
Thank you.
Alan Moskowitz?
Yeah, hi. I can give you maybe a tip or two with regard to sort of getting your bladder at the right fullness, all right? What I did was I bought, well, you may have one, a male urinal, basically a bottle that's got graduations on it, so you can see, how much the liquid is in it. And so what I did was, after the scans of the radiation, I filled up that bottle to see how much my bladder held, and sort of said, okay, I could tolerate this level of fullness, okay? And if it was a little low, then next time I changed my drinking procedure. I started sooner, or I drank more water. And after about a week, or maybe a bit more than that, I could get it down pretty good. And so you'll know, it gives you feedback. You'll say, okay, this is before the scan, it was uncomfortable, and you look at the body and say, okay, that was whatever, 800 mils. I can't do that. So it's trial and error, of course, but at least you get some feedback, okay? That was one very good tip. And I remember at the conclusion of my treatment, and I rang the bell, they said, gosh, you were remarkable. You really were very consistent in your scans and the bladder volume. I said, well, this is why. I carried it with me in a gym bag, and it was very helpful.
Okay.
The other comment regarding the bowel stuff, I didn't have to do that. but I can tell you that if you avoid a diet, particularly the day before, with too much fat, you might have an easier time. A fatty meal, and not a whole lot of fat, but it will be constipating. So, for example, I had to go into these hyperbaric chambers a few years back, and you're locked up there for, 3 hours. And yeah, they give you a urinal, but they don't give you a diaper. So, but basically, I avoided eating pizza that night before, the day before, just because pizza for me, not necessarily for everyone, tended to be constipating. So there are other foods I'm sure you can think of that might, make having regularity a little easier. Okay.
Good stuff. Thanks for sharing.
Did they mention a white diet to you? They must have if you're eating chicken and rice.
Sorry, a white diet, you said?
A white diet.
I haven't heard that term. I'm on a low fiber diet, 100%. So
it's essentially that, right?
Yeah, which is opposite, because I was trying to do Mediterranean before I, was asked to go to low fiber for the proton radiation. But I only have a month left, so hopefully I can get back on that diet. I was feeling great on that diet.
So, Billy, one thing you might want to do is ask Dr. Belusic if you can get a referral to the dietitian. There will be a dietitian as part of Sylvester, and they can help you work with the right foods to eat whilst you're going through your radiation.
Took advantage of that already. So,
okay.
The pizza I'm eating on the weekend, and Monday I had an issue, first thing in the morning. So I know now I can't, get too crazy on the weekends. But Alan kind of validated that for me. So yeah.
Okay. This too will pass. You'll be another 30 odd days. You'll be through this, and you'll be back to your healthy, heart healthy, prostate healthy, Mediterranean, whole fiber diet. Jimmy.
I was given the white diet instruction, and I couldn't handle it because it was a bunch of food that I don't used to eat a lot of, and I tried it a little bit, but I found in my later life, that white bread, pasta, if I lean too heavily on those kinds of foods, I get constipated. And I decided, okay, I'm going to just, meet with them and say, I don't want to do this. And so I did. I said, I'm protesting. And they said, what do you eat? And I told them, and they said, if you leave out the kale, we can work with it. And I said, okay, why the kale? And they said, that stuff is just, we don't want that in there. But other than that, I returned to my regular diet. I'm not saying that you should do that, but I think that the whole white diet thing may be something that works for some, but not all. And is one of those blanket instructions that maybe might not fit you. Make sure to exercise plenty. You don't have any problem drinking water because you got to do it when you go to the table. And also know that it's a nightmare sometimes. I mean, I really appreciate what Alan said about the bottle and, doing what you can, but I found it was always too much or not enough. The problem was I had to wait a lot of times. It was always such an inexact science. I'd be waiting in the room with all the other guys, and some of them took too long. And sometimes they take a lot longer with me to wait for the RO to look at the scans and get back to me. So the whole thing was on a schedule where sometimes I was on the table and I just could not bear. But they said, hold on, we're almost there. And by the time I was finished, I could barely get off the table. I was so full of urine. And fortunately, as I always say, there was two very, very attractive young women that were there to help me. And I don't think I could have made it without them.
Luckily, I haven't had that issue with holding. They're pretty efficient there. But if I do fail a scan, and then I go back into the queue, sometimes that's challenging because I'm ready, but then I'm not next to go in. And so, yeah, I'll be glad when this month is over. That's been the hardest part. Other than that, it's been.
It'll be over before you know it.
Thanks. Dr. John, you mentioned, how did I get approved or what insurance did I have? I'm assuming this proton radiation is kind of a rare thing to get approved. I mean, I feel pretty blessed to be having it. Is that accurate and why you asked the question?
Well, at first it wasn't being paid for, I don't think by Medicare either. And then I brought the question up maybe a year ago, and somebody in the group told me that it was now getting covered by Medicare. If that's true, then the other insurers usually will follow suit.
Yeah, and it sounds like it's very accurate. It just hits the mark and stays there. So from what I've researched, I know there's a ton of different radiation techniques, but I definitely feel pretty fortunate to be getting this one. Hopefully it doesn't damage any of the group's tissue, and hopefully I have a better long-term outcome as a result.
Then he wanted to talk a little bit about the disappearance of his sex drive, but I wonder if we should bring it up next week since you're probably feeling a little pressed for time now. It's up to you, of course. I don't know.
Yeah,
I'm fine waiting. I appreciate everybody's time so far.
Thanks, John. Yeah, feeling moderator drive. David Muslin, you're on a tight schedule. You wanted to talk.
Yes, sir. Hi, everybody. Okay, Rick, you put me to the task of getting a hold of Dr. Keishan and working on the ANDROMEDA trial in UCLA. I have officially been accepted, and I got the arm with the 2 cycles of Pluvicto.
Okay.
So it'll start on July 27th. Got to go fly out there probably 4 times, but it'll start on July 27th. And one thing I forgot, and I heard it here, they really don't want me traveling back for like 72 hours after the Pluvicto because of the radiation.
Yeah.
Is that pretty much true? You got to stay away from loved ones for at least 3 feet, and they don't want you traveling for 48 or 72 hours.
Yeah.
So it'll be interesting to see how I do and what we learn from it, and we can all learn from it.
Yeah, I mean, it is pretty much true. And those of you who have done Pluvicto, if there's anybody in the room tonight, can confirm that, because if you're at home, they have you sleep in another room to your spouse during that time, and they have you use a separate bathroom, lavatory. So I can see that would be the case. I did mention to you before that UCLA has a hotel which is supposed to be pretty nice, and it's really close within walking distance, because one of our guys just finished treatment with Keishan from low intermediate, and he stayed there. He was there for quite some time. So I would say look into staying at that hotel. It's easy, it's convenient. It'll work well for you. And let me know if you want to talk to the guy.
Okay.
He lives in Malaysia. He's back in Malaysia now. He's an American, but I can connect you to him if you want to know more about the hotel.
No problem. So I see Len is looking very inquisitive. I see Len looking inquisitive. So do you know about the ANDROMEDA trial, Len? Are you familiar with it? You're muted. You're muted, Len.
Very astute observation, David. I was trying to refresh my memory on the ANDROMEDA trials. That's what I was doing. I was looking it up.
Got it.
Well, we can tell you. I can tell you very quickly. Make it easier than David. It is it's a trial for recurrence, oligometastatic recurrence, that provides spot radiation to the lesions, plus a some radioligand therapy, either 2 treatments of Pluvicto or 1 treatment of actinium, and no hormone therapy. So the systemic treatment with it is the radioligand, and there's no hormone therapy associated, which is great.
And so David is going with the 2 doses of Pluvicto, is that right?
That's the arm that I got. Yes, sir.
Yep.
And just a quick bit of history, Len, just like you, I'm on darolutamide for 6 months and then I get off. My PSA has risen up to 2.5 now, and found 2 spots, one on my T12 spine, and possibly one in my lymph node in the mesorectal lymph node. That's a maybe. And this is year 3 of the same cycle that basically you're on. And I've been doing great. I feel great, but I'm talking to Rick, and to get a couple shots of Pluvicto might slow everything. The intent is to slow everything down. Instead of doing it every year, maybe it'll be 2 years, maybe it'll be 3 years, to get the cells that are microscopic, the metastatic cells. So it'll be interesting. What type of side effects do you think I should expect on 2 cycles of Pluvicto? Anybody have an answer for that?
Oh, no.
Yeah, I had 3 cycles, and I must say it was a very easy and non-toxic regimen to face. Only had some dry mouth, which still persists, but compared to other therapies, I feel I hate to use the word easy, but it was.
Got it. So they'll do the the way this works is first cycle of Pluvicto on July 27th, then 6 weeks later the second cycle, and then 4 weeks after that do the radiation. Get a PSMA test in between, obviously, but it'll be interesting to see how I do. So I'll be reporting in. It'll be interesting.
Really excited, and we recently had communication with Dr. Kishan, and he was terrific and really respectful and grateful, and so I think it'll be a good experience, and it's great that we're sending more AnCan'ers to him. I am very hopeful for this treatment, particularly for guys who don't want to have to deal with hormone therapy, that maybe it'll become standard of care. We've got somebody else trying to get into it right now, but they've got insurance issues with UCLA. That's probably the most difficult thing to overcome. The other person, my buddy Dave, was accepted by Dr. Kishan, but the insurance issues are intervening. So that's probably the toughest aspect that you have to resolve. And then I've got somebody else that we're thinking about sending out there, a gent who's recurred after many years. Actually, he hasn't recurred. He's just progressed over 16 or 17 years and suddenly found. So he's probably, we're not sure if he's eligible or not, but he fits right in the profile.
Got it. And by the way, I ran everything by Dr. Russell Schmuelowitz at the University of Chicago. Highly supports getting into this trial.
Oh, great.
His trial, or the trial at the PSMA-DC trial, you would have to do 4 cycles.
Right.
And I just don't know how great 4 cycles would be for you. It's unknown, but he highly recommends Kishan's trial. So I'm excited.
Great.
So we'll see how it does.
Great. We love it.
Thank you. Thank you, guys. And thank you, Rick, as always.
Good luck, David.
Thanks.
Jim Marshall, your hand's up.
Yes. Hey, David, you should carry along some kind of statement, especially airport wise, because you may trigger the radiation detectors. And if you do, you will create quite a stir in the airport. So
Thanks, Jim.
it's true. I have heard of that. And so just
Yes,
a
sir.
word to the wise.
I've even
Thank
heard
you.
of people being pulled over by state police who have radiation detectors in their cars or by the side of the road. I don't know what.
Thank you, guys.
Frank Champa?
Yeah, they give you a card to carry if you get pulled over when you take it to the airport. I mean, so you don't have, I mean, just have to show them. I went through the airport one time and all the bells went off, but they just didn't pay attention to me. I just kept going. But they do give you a card to carry. Actually, good if you get pulled over by a cop. You can tell them you got radiation. They're not going to give you a ticket.
Yeah. How long after you took the Letitia did you fly, Frank?
A week.
Week.
Week
Okay.
later. I was kind of like trying to be considerate. You know, people like you can't sit next to anybody that's pregnant. That's for sure. So you got to tell the stewardess, you got to look out. Hey, if you get to your seat and say they see somebody 3 seats away, pregnant, you got to go, look, I can't sit here. So it's basically pregnant mothers, little babies. My wife, we isolated from each other for like 5 days.
Yeah.
But we ate together after a while, but it's the babies that we're always more concerned about.
Yep. Okay.
You'll be all right, man. It'll be easy.
Thank you, Frankie.
Okay. Moving on to Avery Beckton. You hear us and we hear you? How are we doing?
Yes, I can hear you.
Excellent. Excellent.
I'm sorry that I was having problems with my computer. I'm at a library and
Yeah.
it wasn't working. So I'll be very quickly with this. I was
Wait, no. I will guide you through it just so that
okay.
the questions are in order and we don't miss any, and you'll have an opportunity to ask the questions or put
Okay.
in anything that I've missed. So, how old are you now?
I'm 69.
And where do you live?
I live in Virginia.
How did you hear about AnCan?
Jim Marshall,
Yeah. How old were you when you were diagnosed?
69.
What led you to think you had prostate cancer?
I started getting up, getting up at night more frequently, probably 2-3 times within a 2 or 3 hour period. I was at Fort Belvoir. My urologist, he left, retired, I guess. And I went over to Walter Reed, Dr. Chestnut, and around December and January, my PSA had in December, it probably was like 16, but I had taken some medication that got it that high. Did it again in January, went down to 6, about 6. So he recommended I do a biopsy, prostate biopsy, which he did it. 7 out of 15 came back positive. Out of that, 2 of them was 4+4, and one of them was 3. 2 of them was 3+5, and the other ones were 3+3 on the Gleason score. He called me. I was abroad. I was overseas. Like when I came back in March, I went in and I did let's see, what did I do first? I did a PET, PSMA PET. When he did that, that came back It showed initially, it showed 8 highlighted areas. I'll just say highlighted areas. And that's when he told me that it was metastatic.
Okay. Okay.
So after that, it was just a series of, one of them was in the sternum. So he did a biopsy of the sternum that came back negative. Then we talked about, well, if that's negative, what about the other areas? He showed me on the screen, but I didn't know what that looked like. He just said that the areas that was highlighted, and it showed that in my left shoulder was highlighted, 7 and 8 ribs, number 7 and 8 ribs was highlighted. My sternum was highlighted, but my pelvis was not, nowhere near my pelvis, which they said that was unusual because that's one of the first places that it would go to. So he recommended, Dr. Chestnut recommended that I do an aggressive type, which was the ADT, which was the Lupron shot, and the pills, and I forgot the name of the pills. I can't think of it, but it was a 3-month cycle. I started that on May the 4th. That was my first, that's when I first started. I took the shot, and that's when I first started taking the pills. It was those, I want to say it was 1,000 milligrams of that abiraterone.
Okay, abiraterone, yeah.
And then the prednisone, which was countering that. Then he told me to start taking calcium to help fight that. I went in today and spoke with the radiation, I can't think right now.
Oncologist.
Yeah, the radiation oncologist. And he looked at everything, and he said, initially they was talking about doing radiation. He looked at it today, and he said, look, he says, even in the areas of your ribs, it just look highlighted. It don't look, I can't think of the exact words he said, but it is unusual. He said that my case is unusual. And he said that he would recommend that I would not get radiation for 6 to 9 months. My PSA in April was 5.6. Last week it was 0.42. So that's why they recommended that just continue 3 months with the treatments, ADT treatments, and go from there. I probably left some things out, but that was pretty much the gist of it.
Yeah, that's a good account. I neglected to ask where you're getting treated.
Oh, at Walter Reed. Reed. Just to let you know, I did do genetic testing, and that came back negative. My father, he passed from prostate cancer back in 30 years ago. My brother, he's 72. He had his prostate removed about 3 years ago. I asked my other brothers, and they had no complication at all. Their PSA levels were fine. And that's 2 other brothers. They're older brothers. One of them is 80 and one of them 79.
So who would you consider to be your quarterback doctor at this point in time that's running your care? Still Dr. Chestnut or somebody else?
It's interesting that you asked that question because just my little knowledge and reading all the reports, I printed everything out in Genesis. And I just, when he told me that, I just went a deep dive. And I was concerned about, at first, you go through that shock, but then I was concerned about, you give me a sternum biopsy, that come back negative. Then I read some of the reports that says the impression says that this is unusual. Most of the time it go to the pelvis area, and it's not even in the pelvis. You don't have any pain at all. I'm still playing golf 3 days a week, working out, 2 days a week. I have no pain, never had any pain. So they said that even today, he said that this is unusual, and that's why he said that he would not recommend radiation. So to answer your question about who my doctor is, at this point, I'm gonna get a second opinion. I'm just trying to figure out who I want to go to get that second opinion.
Okay, well, we're going to help you with that, Avery. Our experience with many guys over 5 to 10 years has been that Walter Reed is not the best hospital if you have more advanced cancer, because they're not set up to treat advanced cancer. Chestnut's a great surgeon. We've seen many people that have been he's operated on. Their radiation is okay. They don't have the most recent equipment, but they don't have anybody who is running, who can run your care, because this is beyond Dr. Chestnut. It's beyond his knowledge. He's a urologist, and especially in a case like yours, which is unusual to say the least. You need more. You need a strong medical oncologist, and as Jim may have told you, we direct most of our people in your area to Dr. Palla at Sibley, who has seen a whole bunch of veterans. We know because we've sent them to her, and I'm sure she sees others too. But within community care at the VA, we've gotten people to Dr. Palla, and I'm sure working with Jim, you can figure out a way. Do you have TRICARE?
I have TRICARE, and I also have Medicare for Life. Medicare.
Okay, yeah. So if you have TRICARE for Life, it's easy to get to Dr. Palla. And just to be respectful, are you an officer or not?
No, I was enlisted.
Enlisted, okay, because we have many enlisted guys, some who are here right now. We have many officers as well. But yes, with TRICARE for Life, it's no problem. And work with Jim. And if it were me, I'd get my ass over to Dr. Palla as soon as possible, shift all of my treatment to Sibley, and let's try and figure out what's going on with you. Have they done any genomic testing?
Genomic, no, I have not. If you can explain that,
I can explain it. So they've tested to see if you inherited anything, correct?
Correct.
And that was negative.
Correct.
But have they tested to see if you've made any mutations yourself?
I don't have an answer for that, because when they did the swab, and he said that I had to look at the reports and I can ask them that question. But when they did the swabs about less than 10 days later, they came back and said, look, you don't have
negative.
it.
So with a diagnosis like yours, the guidelines clearly say that in addition to that swab, you should get a second test, which they can do either from tissue. So in your case, because it's so recent, they could do it from the biopsy tissue, or they can do it from your blood, which might be more difficult at this point since you've now been on hormone therapy for a few months. But that should be sent out, and we should be looking to see what type of, if any, mutations you've made yourself. And Dr. Palla will take care of that when you go to Sibley. But it's really important. This is, again, one of the reasons why we're not super comfortable with Walter Reed, Walter Reed knows they should do it, but they don't order it.
Could you tell me what the name again, or you can spell it?
Well, it's called, to make it easy, it's called Next Generation Sequencing. Next Generation Sequencing is the easy name to remember.
Okay.
And what that stands for is they take your tumor and they analyze the DNA in your tumor.
Okay. All right.
And they come back and tell you if you yourself have made any mutations rather than what you might have inherited from one of your parents.
Okay. Okay. Yeah, I had I went to a primary care and I told them about my diagnosis, and they recommended a urologist in UVA in Charlottesville, I want to say, but I have not. The only thing I did was I printed out all of my reports, all of my scans that was in Genesis.
All right. Who did they recommend? Who did they recommend at UVA? What was it? Dr. Green?
Hold on just a minute. I got it on my phone because it's scheduled for August.
Yeah. Look, you don't need a urologist.
Okay.
Again, the primary care docs may not get their arms around this. You don't need a urologist. What you need is a genitourinary, which is a fancy name for below your belt, medical oncologist. So you need a medical oncologist who specializes in the cancers below your belt.
Okay.
And that's Dr. Palla. So even if they sent you, and we know Dr. Green well, but we would send you to Dr. Palla rather than to Charlottesville for a GU medical oncologist. We like Dr. Palla better, our preference.
Okay, yeah, that's fine. I have no problem about that. I can talk to Jim and set that up. Yeah, not a problem at all.
Okay.
Avery, look in the notes. There's some, good information there that you could jot down in the notes in the chat.
Okay. Okay. Yeah. Thank you. Thank you very much. And I'm sorry. Go ahead.
Yeah, I was going to hand it back to Ben actually.
Yeah, I just have one other thing. You were speaking just now, and as I was going through the last month of my research, I kind of came to that conclusion as to what you said about Dr. Chestnut, that he was probably a great surgeon, but in terms of this type of treatment, that was just my gut feeling. So what you just said kind of validated what my gut feeling was, what I was feeling.
Yeah. I think the bottom line for most of us is that we feel urologists and urologic oncologists are great, but they're there in most cases to treat you up until the point that you've had a radical prostatectomy or you've had radiation. And if you've had radiation, they've already turned you over to the radiation oncologist. But neither the radiation oncologist nor the urological oncologist are really there to treat you if you have metastatic disease or if your disease has come back. And so we tend to move people along. And for this isn't true for you at Walter Reed, but in many instances, for financial reasons, the urologists and the community and the radiation oncologists don't like to move people along.
Thank you very much. And again, thank you for being patient with my computer issues.
Happens to all of us. Jan, you had something to say?
Yeah, Avery, I would just suggest you consider taking someone with you to hear what goes on during your medical visits and or record them. so that you can play back and study what you find out there, because there's a lot of information that comes through there. Just a suggestion.
Yeah, and that's what I do is I do record it.
Oh, great.
Excellent. Thank
Good
you.
job. And keep coming back to us, Avery, especially after you see. You can tell Dr. Palla that AnCan sent you, and she'll probably smile. But I think you'll find you're in very good hands with her. And while she may not necessarily change your treatment, she's going to do more tests like this next generation sequencing, and she's going to verify some of the things that we're not so sure about. I mean, it is very strange that we've got 8 spots that light up on a PSMA, and yet that sternum comes back. That sternum biopsy comes back negative. I mean, we could, I'm not sure it's worth it, but we could suggest you send that sternum biopsy out for a second opinion. But I'm not sure it's really worth it when you've got 7 other spots that light up. So the likelihood is the prostate cancer is metastasized, because that's what that scan is telling us. They're seeing PSMA in places they shouldn't be seeing it. And who knows why we didn't get an answer from the sternum, but that's worth digging down and seeing where she goes. But if you do decide you want to get a second opinion on that biopsy, don't do it. I don't want to say don't do it. Sibley's part of Hopkins. Hopkins lab is very, very, very good, but it's not as good as it used to be. And the man who used to lead that Hopkins lab is where we send for our second opinion. So that's where we'd send you. But getting a second opinion at Hopkins is not all that bad.
Well, with that, and I understand that there's some really extensive knowledge in this group. With that, I will talk to Jim about going to Sibley about that. Would that be considered the second opinion going there to her?
Oh, if you went to Palla, yeah, that's not just a second opinion. We'd suggest you make her your quarterback doctor.
Okay. All right.
Okay, and as you know, Sibley is part of Johns Hopkins now, so you have access to other facilities at Johns Hopkins, and they do have a good pathology lab.
Okay, I can check on that, and Jim, I'll probably reach out to you within the next 24 to 48 hours. Yeah, thank you very much. I really appreciate this. This is helpful to me, very much so. Thank you.
Well, thank you for coming. We do hope to see you again.
Yes, I will get the date. I know you're meeting. I think Jim said it 4 times a month, and I just want to make sure I put that in my calendar so that I can get tagged.
Sounds good. Alan Moskowitz. I'm sorry.
So I just want to say, Jim will make sure you're signed up. We have your email address. Jim has it. And we'll make sure, and then you're not just in your calendar, but you'll get a reminder newsletter from us a couple of days before each meeting in your email.
Great.
Okay, so I haven't updated in quite a while. I thought today would be a good day because I got results of a PET CT, a PSMA scan, the PET CT type, PSMA, and met with my oncologist, and that was Chuck Ryan at Sloan Kettering. So the last time I had a PSMA scan was 18 months ago, and in that time my PSA has crept slowly upward. It's about 2.3 right now. The doubling time is depending how you calculate it, between 10 and 14 months. And he looked at my data, the historic data, and he said, yeah, it's probably closer to a year. Initially wanted to talk about starting treatment around now, but when he saw the doubling time was low, and based on the last time I started at PSA 5, he was okay with that. So I can wait, probably have to start something, certainly next year, maybe April or September, in that time frame. So I did talk with him about the scan in detail. I have lung nodules. I still have a few, but he said I wouldn't even do anything now with them. We had previously talked about SBRT radiation for one of them. And he said, yeah, he says they're not really avid enough, so they're not glowing as much. And he said, we can wait and see. No urgency. Frankly, I was uncomfortable with that answer. And I said, can't we talk to a radiation oncologist? And even though I might not treat it now, which I probably wouldn't, one of them, at least if it's the same one as last time, is close to my heart. And going back when I had the last detailed study of that, the advice was, it's too close, you can't biopsy it, and radiation was not considered to be an option because, again, potential cardiac damage. Nevertheless, I am seeing through Sloan a radiation oncologist. I just need to know whether or not this could ever be done, because I don't want to end up with, a treatment regret, not even considering that. The question I have is types of treatment available. I looked through my notes and the previous discussions, and I bounced off a number of things. And he was very comfortable with darolutamide, but he was not comfortable with it as a monotherapy. And he said, look, there are trials that show, he mentioned Embark. I don't know how relevant it is that two agents, two drugs, better than a single one, which I've heard here and which I know. And the first time I had treatment was enzalutamide and Lupron. And he said, no, if you had treatment, you should have two drugs and you should have probably Orgovyx would be better for me because my testosterone is not recovered. It's still down around 200, sometimes a little less. And have that with Orgovyx and with, darolutamide. So I said, well, okay. And I went through the list. I said, could I have, if you can't give me monotherapy, tell me about, for example, the estradiol patch. I heard the seminar, I watched it afterward again, and I gave him the article, and all he said was, I'm familiar with this. They approve it in the UK. It's not the standard of care. And he says, it's not for you. He said, why take a risk when you have a condition that's not too aggressive? Same thing with doing the radiation. Why do SBRT or whatever when we can address the whole thing? He said there could be systemic prostate cancer. Yeah, you have these spots in your lungs and nothing else is avid. You have a couple of old things on the bones, which not relevant. And he just said it could be somewhere very tiny and we don't see it. So he says he wasn't big on doing that. And I don't know if there's anything else that would be appropriate. I mean, he was pretty insistent. And my wife said I gave too much pushback today on him. And I said, this is how I operate. I said, I need to have some rationale as to why he feels the way he is and what he did. And that's sort of where I ended up. I mean, I'm lucky to be in the situation I am. The last treatment was in 2022. And I lost muscle. I couldn't exercise as much. I had fatigue due to a lot of hemorrhagic bleeding in the bladder. And it was very fatiguing when you lost a lot of blood. So I don't, any thoughts, anything I'm missing in terms of potential treatment? I'd like to spare my testosterone. I really don't want to lose more muscle. I'll exercise what I have to do. But remember, it was tough for me, over the past few years with various, back surgery and all of that. And so I don't know that I could barely do more than maintain muscle mass. So any thoughts?
I mean, just to be clear, he's saying lay back, give it another year. We probably won't see anything during that.
Well, my if I follow the prediction on my Excel chart and all, I will hit PSA 5 in April or as late as September, assuming the doubling time doesn't change radically. So basically it could be a year, and then I would have treatment around PSA 5. I don't think I would go higher. I know the last time, Ben, when I saw Dr. Chen at Sloan, and when I talked to Dr. O, then at Mount Sinai, they were happy with PSA 10 for Dr. Chen, and Dr. O said, hey, if it stays like this, you could go to 20. Which I wasn't comfortable with that. So, he gave me, when he said that, then I was very comfortable with 5. Yeah. And so Dr. Bose said, hit it hard, give yourself treatment for a year. You might buy another year of no drug treatment. And so, hey, I have no complaints. I mean, I have been good since 2023 with no treatment. And hopefully get to partway through next year, or hopefully most of the way. And I'm grateful.
Just a follow up, because from what I understand from my case, with the amount of cancer I had, my PSA was relatively low. And so in researching it, it sounds like sometimes with these aggressive cancers, they're pretty slick and they'll produce a lot of PSAs, and I know we're all probably different. I don't know if that's universal for aggressive prostate cancer, but I just wanted to throw that out there. Like, relying on the PSA, number, can be risky, especially like I said, in my case. So I will probably have a lower threshold, as I get this down, and hopefully it never comes back, but if it does.
Yes. So you're absolutely right. What motivated me to agree to get the scan, you wanted to do it last December, and my PSA was, half what I got now. And I said, I'm not going to see anything. What's the point? So I wanted to go another year. I said, what good is it when it's so low? And he said, let's go June. We met that at the 18-month mark. And I said, fine. And then I was happy because I read an article that exactly to your point that said cancer can progress even if the PSA does not move or move up a little bit. And when I read that, it sort of, I don't want to say it scared me, but it motivated me to, move it along. So yeah, exactly.
But you got a scan, and things look good. I mean, I think you should just take the good news.
Yes, no, I agree. It's good. It's good news, and we'll revisit PSA and testosterone quarterly, and have another visit with them at the end of the year, and we'll go from there. If something markedly changes, I'll address it. But I thought going back to my question, is there any other treatment that I should be considering, or any other drug combo? I mean, it's not going to be radiation.
So I guess, Alan, what we're saying to you is there's nothing else you should be considering now.
Okay.
Because you know where you're going for the next 12 months. So anything we say to you now may not be the case 12 months from now. Who knows? Monotherapy could have been FDA approved.
Right.
Some doctors are very comfortable with prescribing monotherapy, just as some doctors are comfortable prescribing estradiol, but not all are. And Chuck Ryan is evidently not. And so, but if you really are anxious to do monotherapy, then we'll say to you, okay, you're going to have to switch your care and you're going to have to drive over to Greenwich and you can go see Dr. O, because Dr. O is going to give you, Dr. O will give you monotherapy if you want it. Now, are these, and I say this with the greatest respect to Dr. Paul, because he asked me about this before, are these standard of care and recommended by NCCN? No, they're not, which may be why Dr. Ryan doesn't want to prescribe it, but there are some very, very reputable, strong doctors who are comfortable prescribing it. And if a man really wants it, then you've got to go find a doctor who's willing to do it.
Yeah.
And some will, some won't. But I don't think there's much point in having a discussion with you about what else is available when
I get it.
you're not going to do anything for you. Yeah, we could send you like David Marsden. We could say, yeah, why don't you go out and if you've got any spots that are available, those nodes, maybe Dr. Kishan will fire at those nodes and give you 2 sessions of Pluvicto or 1 session of actinium and do that instead. But there's no reason to do it right now because you're static for a year.
Yeah, no, I understand. Well, I'll know a little bit more just about. Well, I am going to see the radiation and oncologist just to help them.
Okay, I think we got to move on, Alan. I'm sorry. I'm just.
Thank you. Yep. Great. Thanks.
Thank you, Alan. John Maxwell.
Hello. Yes. I went through and I got my first test back 3 months after radiation. I was at 0.13 on my PSA and my testosterone came back to 230. I heard from a friend who had radiation and he said that he had bleeding from the rectum, that I should watch that as a potential problem. What can you tell me about that?
I could say a word about that. Not that I've really experienced it very much. When I got my radiation therapy, I had quite a bit of diarrhea and then it cleared up afterwards. And my radiation oncologist did not use a barrier between the prostate bed. Let's see, did I still have a prostate then? No, I didn't. And the rectum. You still have a prostate?
I do.
Right? So I recently read an article comparing the Barrigel with the Spacor that pretty strongly favored the Barrigel. So there is a barrier that you can have injected in between the prostate and the rectum in order to help protect the rectum from getting too much radiation.
He got his bleeding like 2 years after the radiation.
Right.
Oh, that's a delayed type radiation proctitis. Yeah.
Yeah. I mean, there's nothing you can watch out for at this point in time because you could have a delayed effect of radiation proctitis, or you could have a delayed effect of radiation cystitis, which we hear about quite a lot here. Is there anything you can do to stop it? No. I mean, what's done is done. We don't know how your tissue will respond. Dr. John had some very smart words on that, I think, last week or the week before, that the tissue absorbs the radiation over a very long period of time, and it may break down and it may cause problems. Some of us have had issues. I've had radiation cystitis for probably a year and a half after, radiation proctitis since probably a year and a half afterwards, and I still get it from time to time. But it's just not a big deal. So I think in the spirit of, I mean, these people who say, well, you know, be concerned about it, you have nothing to be concerned about right now. If you see some spotting and a little bit of blood, don't get freaked out. It's probably radiation proctitis, and we'll talk about it when that happens. That's what I would say. To John?
Great, I appreciate the insight.
Let me make sure that I'm understanding. You're talking about some future radiation again that you're thinking of getting.
Future.
Right? So,
yes.
So maybe let me argue with Rick a little bit about this. So let's imagine radiation proctitis 5 years into the future. One of the factors that determine whether that happens is the radiation dose received by the rectum, now or in past radiation. So why not shield the rectum now in order to reduce the total radiation exposure of the rectum in the service of 5 years from now?
I've never heard of it done where they put in a barrier after the radiation. I mean,
no, before.
He's had the radiation. He's all done.
My treatment's all done. My radiation's all done.
Oh, that's what I just asked you, and I thought you said you had future radiation still coming.
No. He's worried.
All done. Oh, okay.
Okay, so I mean, he's worried. Well, what if I need more radiation in the future? We'll talk about it then. You know, I mean, there's one of the things. What the philosophy in this group, in AnCan, very much is we try to keep you in the moment. Because if we start allowing people to worry about what if Alan Moskowitz wants to know, well, what am I going to do a year from now? Well, then that is anxiety. You know, if you worry about the past, it's depression. If you worry about the future, it's anxiety. So stay in the moment and don't worry. And that's part of our job, to keep you now and here. And so when a guy comes to you and says, well, you know, I had issues, and just watch out because you may have issues. You may have issues. That's one of the risks of having radiation. But I don't come in and talk to people about, worry about radiation proctitis, even though I have it. Len doesn't say worry about radiation proctitis, even though he's had significant treatment, more treatment than I've had, because we don't want to worry you about that stuff. And I would love to talk to your buddy who told you this, because I'd like to have a little chat with him and say, don't be telling people this. What's the point?
So here's what I got from this. Here's what I got from this. It's a possibility maybe in the future. Deal with it when it comes, and it doesn't sound like it's something that's acute or difficult. So I feel better.
Good. Now, most of the time that's true. There are occasions when radiation proctitis can be can be a problem. And there are times when radiation cystitis can be a problem. I got radiation cystitis probably three or 4 years old. All of a sudden I'm like peeing blood, but it's not bad. I'm getting worried. And you know, I made a deal with my urologist at the time, and he said, well, if it happens again, you've got to come in. I got to look at it. And I said, that's okay. And it did, and it turned out it wasn't very much. But there are people, and we've had them in this group, who have significant radiation cystitis, and they have pain, and they go through hyperbaric treatment or something similar. But we worry about that when it's at that point, not when we're doing great. So if you got from this don't worry, be happy. We're happy.
I got it. I'm good. Thank you. Right?
And not too many people leave this call feeling better. Tony Fig, what's shaking?
You have a hand up.
Oh, I beg your pardon. Yes, Thomas Matika.
Okay, I was distracted here. I just wanted to say to take me out of the queue, the Orgovyx discussion covered what I wanted to bring up. So take me
Excellent.
out.
Okay, thank you.
And thank you.
Billy Ingersoll?
Yeah, sorry, so many questions, but I have an in the moment question. I'm in the middle of proton radiation, and my radiation oncologist, Dr. Mahal, did not think I needed a barrier for the rectum. I don't remember the reason, but I must have been satisfied with his answer.
Right.
But hearing you guys discuss that, it may be too late, so it's a moot point. But I know there was another guy that's getting the proton radiation to the prostate, and he's got one. So anybody know why I might not be getting one? Is that common practice?
I can tackle it, but would anybody else like to?
Protein supposedly is precise enough to maybe obviate the need to have a bigger space between your rectum and the prostate. But that doesn't mean that some radiation oncologists using proton don't also kind of add the extra distance just to be certain and sure. So I think it's an individual decision based on the radiation oncologist's confidence that his proton beam is precise enough to avoid rectal injury.
Thanks, Paul.
So I'll just add to that. These rectal buffers are controversial. A lot of doctors will use them. Some doctors prefer not to use them. There's some concern that putting in a buffer can move the prostate, can move the tumor. They can shift around during radiation, and some doctors prefer not to use them, including Mac Roach, who was my doctor. So I don't know what Dr. Mahal's philosophy is. Dr. Schallhammer's explanation just now is a really good one, and it may be that you don't need that it's more accurate. But I also don't know if you can. Insert after you've started. That's a whole nother issue too.
Yeah. I'll ask him during my next follow-up and bring it to the group just for education purposes. See what he had to say. I'm sure he had a great answer.
Be great. I do one other thing I want to say that nobody picked up on, and I picked up on it and then I forgot to say something. John Maxwell, 230 testosterone, 3 months after coming off treatment, gets a gold medal. Unbelievable. Unbelievable. I mean, we never, ever see that type of rapid recovery. And it's something that we've sensed with Orgovyx before, but it's one of the reasons why we love that Orgovyx. And especially in men who are in their 60s, you come back, not everybody, but you can come back so quickly. And I think it's worth a comment. 230, and you only, when did you were off all hormone therapy 326? When, I can't remember, when did you stop your Orgovyx? John, are you there? Okay, well maybe he did drop off, but I think he dropped off his Orgovyx. I'm not even sure, but it's definitely worth a comment.
Okay, Tony, you have the floor.
Yeah, as an update, My PSA has been going up fractionally over the last year, and I had a PSMA PET scan done in February, and that did not show anything. However, I've had 2 hip replacements, and there was a lot of shadowing going on as a result of the hips on the PSMA scan. So I just had another PSA test done, and it doubled from the time before, so it's at 0.54. So my GU medical oncologist is ordering an Axumin scan for me that'll be done in July. He thought that may be able to pick up something. He feels it might be in the pelvic bed. So I've got that scheduled. I also had a CT scan done because I'm going to have shoulder replacement, and they've got to make some special device because my arthritis has deteriorated the bone. And in the CT scan, they picked up a spot on my lung. So we don't know if that might be something that's causing the increase in the PSA, but I'm having a CT scan done this weekend on that spot, as well as some more for the shoulder replacement. So that's, we're just going to have to wait and see what those show up. I also had a rather unusual thing happen.
Hold on a second, Tony, before we change the subject. Have you ever had a positive result on a PSMA scan in the past?
No.
Okay. And how many have you had?
3.
And you say you're at 2.54?
I'm at 0.54.
Oh, 0.54.
0.54.
Yeah. Well, again, it's highly possible you don't make PSMA, and it's really rewarding that they're willing to order that Axumin scan, because as you remember, Tony B up in your area had a lot of problems getting them to order an Axumin scan. So the fact they're doing it right away is great. And let's see what it says. I mean, kudos to I always forget his name. It begins with a C.
Dr. Garcio.
Dr. Garcio, yes. Kudos to Dr. Garcio for going straight to the Axumin scan.
Yep. He doesn't think that spot on the lung really, it may not even show up this time because it was described as a 2-centimeter subpleural anterior ground glass opacity. And it could be a result of a infection or scar, but we'll see if that still shows up this weekend. The other thing I had is I go out for dental cleaning and x-rays every 6 months, and they've always been perfect, no additional cavities or anything. And I went a month and a half ago, and all of a sudden I've got 12 new cavities. And the dentist was really kind of flabbergasted that showed up. A lot of them have gotten under, the cavities have gotten under crowns, and I've had to have a couple of root canals. But his thought was that the composition of the saliva changed. And I've talked to a couple of doctors, and they said if you've had radiation around the mouth area, then that could explain it, but not from the pelvic area. So I don't know if anyone else has had any big changes in saliva makeup, but that was really unusual to have that occur. And it's been a little over $12,000 so far for dental work.
Oh.
So that's the update.
So what has been your highest PSA in the course of your illness, Tony?
Right now or when it first started?
At any point, how high has it gotten?
5.7.
Okay.
So it never really did go up rapidly, but the cancer did grow very fast from one biopsy time period to another.
Yeah. It's too bad that our dentist is no longer with us.
Yeah. All right. Well, that's all I have for today. So thank you for listening.
You're not on any bone medicine, are you, Tony?
No, I'm not. No. I had DEXA scan and bone scan done, and they came back fairly good that I didn't need to take any medication.
Any more questions for Tony? Well, thanks. That's an interesting update.
Okay.
Steve L., you had wanted to speak?
There we go. Okay, can you hear me now?
Mm-hmm.
Yes. Saw my GU oncologist last week and had some scans or some testing beforehand. My PSA this time was 0.39, which is exactly what it was 3 months prior. So he thinks it's, you know, a very good thing that it's stable, and yeah, just wants to continue doing what we're doing. I have had a couple of DEXA scans. I am on some blood meds, and it's been 2.5 years since I've done a DEXA scan. And I think the protocol is to have one every 2 years or so. And I just wanted to confirm that. And I also wanted to note that he offered to put me back on Lupron. I've recently changed from Lupron to Orgovix, and I'm happy with the Orgovix, so I didn't take him up on the offer, but he brought it up like perhaps I would want to do that. Yeah, so I'm just trying to live in the moment and, you know, enjoy the summer and not worry about what treatment I, you know, maybe should have in the future. But yeah, he did not order a PSMA scan on me at this time. Didn't think it would be appropriate. So just looking for comments on those things.
Sounds good to me. Is there anything that's anything? Oh, Dr. Seneca, what do you think?
Yeah, well, I just think you can get a DEXA scan every year, but insurance companies will not pay for it
Oh, okay.
until every 2 years.
Okay. Well, it's been over 2 years, so I just, yeah, every 2 years sounds good to me.
So I was able actually to get one every year, and my doctor would always say, you can't get one, the insurance company won't do it. I'm on Medicare for what that's worth, and I have been able to get one every year and get it reimbursed.
Yeah, I think if you're on hormone therapy, then they will agree to do it every year. And I think it's probably smart to do it every year. If you're on hormone therapy, because you don't know what the impact of having no testosterone is. So I would go back and say be more comfortable because of my long-term hormone therapy, I'd be more comfortable getting one. Again, advocate for yourself once a year.
Even if you're on bone treatment?
Even more so.
Okay.
Because, you know, maybe if it turns out that what was your last what was your last T-score?
Oh, I don't know it offhand. It was not that extreme. It was in the osteopenia stage, but not very far into it.
Okay, well, the question is, well, do I still need to be on it? Because if you can get off of it, you can get off of it. And if it's gone up and you're solid, maybe you go back and you say, Dr. Fong, maybe what if we dropped the bone support for a while? So I would say yes, it's probably worthwhile. When was the last time you had a PSMA?
Year and a half ago.
More and more, we do like to see. We like to see a PSMA once a year because we don't trust PSA.
And my PSA was never very high. I was diagnosed at 4.5.
So again, you can make the arches argument, which I'm sure Larry will be familiar with, the Andrew Armstrong work that he published earlier this year. Again,
Arches
from
was the study?
The Arches trial.
Okay.
Where he argues that we shouldn't be relying on PSA alone. We need scans as well. And so to scan once a year when you've got metastatic prostate cancer and you're on long-term hormone therapy, I personally think is not a bad idea. If it were me, that's what I would be asking for. But again, I mean, you've got to advocate for it yourself. And if you quote the Arches trial, the Arches paper, which I think Len wrote about that in our April 18th reminder, because I just looked it up earlier on today. So do you keep our reminders?
Yes.
So if you go look at the reminder that was it was either sent on the 18th or for the 18th meeting. I don't know. You'd have to look at the calendar and see what if the 18th was a Monday, whatever it was. But that reminder, Len has an excellent article on relying on PSA. And it also has a quote, and it also has a link in that article to the published paper.
Very good. Thank you.
John, do you want to say something on that? Because I know you and I were in discussion with Alfredo on that earlier on today.
Yeah, it's always been an issue with me, and when we see an article about it once or twice a year, it just reinforces my feeling that PSA alone can miss things. So find Len's write-up. It's really good.
Of course, we also have to say we don't know whether this is of clinical significance.
And boy, if you start using PSMA PET scans as the imaging, then what Ben just said is especially important too. Like PSMA PET scan, Arches and those other trials are only talking about bone scans and CAT scans. Can you imagine what the positive rate is going to be if somebody does this with PSMA PET scans? And then you have to ask the question that Ben just, I think, very astutely asked, which is, what do you do when you find something?
So Ben, just help me a little bit with this. Wasn't, when you say we've got to consider if it's clinically relevant, didn't Armstrong figure it was clinically relevant from looking at the Arches data, and that we were, by not using PSMA, we were missing people that were progressing? Or is that?
Oh, that's great. I have to take a look then.
I mean, I think that was the whole point of the Arches study, of this paper, it's a complicated paper, and I started to read it, and then I thought, no, I'm going to throw it over to Len, because Len's looked at this quite a bit before, and he did look at it and he did write it up. But I thought the effect of that paper was we should be looking at both PSA and PSMA, because if we just follow PSA, we are going to miss people who are progressing.
Right, but we've also talked about, now this is not the same situation, but I don't remember the doctor's name, I don't remember the study, but the argument that you should rely on conventional imaging when you're deciding whether someone is metastatic, that you should not use PSMA PET to decide whether someone is metastatic. You should use conventional imaging and PSA doubling time. These are people, right? It's a different situation, but they're saying that
Yeah. But I would strongly disagree with that.
I mean,
the reason I disagree with it is because we now have PSMA imaging, which we didn't have when a lot of these drugs were approved. And so just because we didn't have them then and we have them now, does that mean that we should rely on what they tell us today? We have better technology. You know, we have better ways of looking at things. Should we still be using the old technology? Should we still be using the old type of TV screen when we've got a new TV screen that we could use? And you know, the concern is, I think, is it going to deliver false positives, like we heard from Avery earlier on today, which is a real issue. And I agree that could be an issue, but I believe you've got to be using both PSMA and PSA and using them in conjunction, and not totally saying it should be one or it should be the other, or we didn't have that then, so we don't need to look at it.
Okay.
Excuse me, are we talking about different subsets of individuals, i.e., confirmed metastatic, castration resistant, being followed versus those who have been treated definitively,
right,
have a mild PSA bump, and then get a PSMA PET absent conventional imaging positive, but just a PSMA PET positive. So I think those are the two groups to distinguish.
Right. So what I'm talking about, as best as I can recall, and I'd have to go back and look, is I'm looking at the group that Armstrong was looking at from the Arches trial. And I think, but I'm not sure, but I think those were hormone sensitive prostate cancer gents in that trial that he was following. And when he looked at the data over a period longitudinally, he was finding men who had metastatic spread without seeing a significant change in their PSA.
Yeah, I think they were metastatic castration resistant, that group, but that's only a memory. It's worth looking back up.
I'm not sure. You could be right. I mean, I can certainly look it up. But you know, I think the takeaway for me is that we should be doing PSMAs and we should be doing PSA tests. I mean, we ran across a situation yesterday where a guy with 3+4 and 2 or 3 spots from his biopsy was getting a PSMA test. It's ridiculous. I mean, what urologist is going to order a PSMA test? They order it because they can. But where we really should be using this PSMA is to make sure that men aren't metastasizing further, because we know that using PSA and PSMA in conjunction gives us a better picture than either one on their own.
Okay, to be continued. Our last man of the night is Pierre D.
Yeah, my video is not on because I can't get my camera to work. But anyways, I just wanted to give an update. I've already communicated with Rick, so he knows what I'm going to be saying. But anyways, I had gone to the Mayo Clinic. I'm Gleason 9, 5+4 with criviform and intraductal and just about every risk factor. Other than that, I'm not a Gleason 10. So anyways, I went from a PSA on a routine physical a year before I was diagnosed, PSA of 2.4. A year later, 8 point something. So fairly aggressive, and we didn't know why. Genetic testing was negative. My brother got diagnosed with Gleason 7 a couple months either before or after me, 3 years younger. So anyways, so Mayo wanted me to do, because my PSMA PET scan after I had surgery and waited a couple months to see what would develop, my PSA started coming up, and I had positive nodes in the pelvis, a couple spots in the ribs, and retroperitoneal nodes. So they had recommended triplet therapy. My oncologist at Roswell Park didn't necessarily agree with that. He thought doublet therapy was more appropriate, although he would have given me triplet if that's what I had chosen. And on this group's recommendation, because I was, sitting on the fence, not knowing which way to go, I went to Dana-Farber and saw Dr. Chaudhary, and for a tiebreaker, basically third opinion. And he agreed with doublet therapy, but recommended that I have somatic testing on my prostate tissue. My Guardant wet biopsy, which was done through Roswell prior to starting my Orgovix and Abby, didn't show anything, but it was a very low tumor pickup. It was like 0.1%. So in my eye, it was probably equivocal. It didn't have enough tumor cells to tell us anything, which is what I think Dr. Chaudhary was leaning towards, because he uses Guardant also. So he said Guardant is fine. It's just that you weren't releasing a lot of tumor cells before you went on your ADT and doublet. Anyways, the prostate tissue came back a few days ago and had PTEN and TP53. So in my mind, that explains why I got an aggressive tumor, and that made me question, should I be doing anything different? So I contacted Dr. Chaudhary, and he said, as long as your PSA is undetectable and you're responding to the doublet, he wouldn't do anything different. And the same thing with Roswell Park. They said, we don't recommend doing anything different because you're responding, and your PSA is doing what it's supposed to. I'm supposed to be starting radiation sometime before my 1 year anniversary, and they would have done it at any time. But because my urinary incontinence is still improving, I've postponed it as much as possible. And then with summer being here, I had 2 or 3 trips that I had planned, bucket list items, and I didn't want to have to mess with radiation side effects. So I'm tentatively signed up to start radiation in mid-October through the rest of the year. And so anyways, that's where I'm at right now. I did have, the PTEN and TP53. Question is, did it go away with surgery, or did the guardant just not have enough tumor cells? If the PSA starts rising, I'm going to ask them to do another wet biopsy, basically, unless there's some tissue somewhere that shows up on a PSMA PET scan that can be needled, for a biopsy. But otherwise, we're going to have to wait and rely on the wet biopsy.
Yeah.
So that's where I'm at.
Yeah. Dr. Pierre, the P10 and TP53 together are a concern, as I said to you. One is usually we can work around. 2 gets a lot more complicated, and in my mind is a sign of cancer that's going to be an aggressive variant early on. And I think you just have to keep a really close eye on that. And Dr. Atish is great. And, I would be comfortable having him as my doctor. And if he doesn't feel like you need to respond, I perhaps might ask him, does he feel, in light of the P10 and the TP53, that it's good to defer the radiation? He may not change the doublet to triplet, but he may want to change the radiation, and I would definitely ask him. And then you have to consider if you want to go along with that. And as I mentioned to you, I definitely we need to confirm that P10 and TP53, because both of them are somatic. And it's possible we got them all. And you're not making P10 and TP53 anywhere else. How would we know that? Well, a blood test would be really great. A liquid biopsy would be great, because it would be covering all of those little bits that are dropping off into your bloodstream, and we're getting pictures of them,
That would be when the PSA starts climbing, I presume, right?
Yeah.
Yeah, because it's undetectable right now, so I don't think.
Yeah, again, that's a discussion again. I think that might be worthwhile having with Atish. Do you think we should allow it to climb so we can check and see if that P10 TP53 is still around? I'm sure he would probably say no, but I would. It's definitely a thought, because that's the thing with somatic. Somatic is in the tissue that you're dealing with at the time, and if that's and if that tissue metastasized, then it would take the P10 and the TP53 with it. But if it never metastasized, then it may not be there. Right. On the other hand, you could how many Mets did you have? I can't recall.
I had 1 or 2 in the pelvis, a cluster in the retroperitoneum, which they considered as one, when thinking about radiation, and then 2 ribs. But my SUV scores were really low on.
Oh, yeah, it's a really, really tricky one. I mean, if it is there any? Have you had a PSMA since the? Have you had a PSMA since the? RP.
No, they're gonna do a PSMA PET scan probably in late September or October prior to starting radiation. While I'm on the subject of radiation, you said to, bounce it off Dr. Chaudhary. Would that be to not get radiation or get it sooner?
Get it sooner was what was going through my mind.
Yeah, well, I mean, they'd do it anytime, but in my mind, I want to get these trips out of the way. So,
Well, I had this with another guy earlier on. I mean, yes, you can take your trips, but if you're a PTEN TP53 guy, you don't want to mess around. Yeah, it's nice to do trips, but what's the most important? You are the most important.
Well,
yeah. Yes.
Quality and quantity have to be balanced.
Okay.
Okay. Quality, these trips are important to me, so that's the quality aspect. And if it knocks off, if it knocks off 6 months or a year, then so be it, basically.
Okay. I mean, the other thing is that if we knew that there were identifiable lesions somewhere in your body, we could then biopsy them and see if PTEN and TP53 are present.
Right.
I mean,
I'm going to get a PET scan no matter what, whether radiation's done or not, or some hell or hot water. I mean, that was the whole reason Quan at the Mayo wanted me to hold off on ADT and all that, was to let the tumor declare itself. And it did. I mean, that's when they picked up Mets, basically. So they started me on doublet because I didn't want to do triplet. But if I'd have gone with triplet, then he was going to do another PET scan after I think 2 sessions of chemo to see if I was responding. Otherwise, he basically said, "I'll see you in a year, and you can get a PET scan then." I'll get one locally through Roswell sometime this fall, basically. For your point, if it shows anything that's amenable to a tissue biopsy, that may be, more bang for my buck than the blood sample.
Yep. I mean, I think it would be. Yep.
Back to tissue biopsies. I guess bone biopsies are highly unreliable. I mean, they tend to be negative, even if there's something there. And
no. The issue with bone biopsies is that you have to macerate the bone, and so you don't get as good a result. So in line of preference, the best thing you can get is a soft tissue biopsy. Following that, it's generally thought that a liquid biopsy is the next reliable, and the bone is the least reliable, only because the bone has to be broken down before it can be analyzed.
Right. With the new patient gentleman that was speaking earlier, he had the sternal biopsy. Well, that's a bone biopsy, and that may be why it's not showing anything. So you recommended that he have a liquid biopsy, and I think that's a real good point.
Okay.
Thank you.
It's a pleasure. I want to just check in with a couple of people here. Dan, what is going on with you? You didn't ask for time. What the heck's going on? What did Dr. McHugh say to you?
I haven't talked to him. I had an appointment on the 18th, and I got on. No, he didn't show up. I looked at the schedule. That appointment was gone. I called him, and they said, "We don't have any record of you having an appointment." And so today, they said they sent it out to the scheduler. Haven't heard anything. So today, I emailed them. I went in the portal. I said, "I haven't heard anything from you. Please update me with what's going on." And she called me about a half an hour later and said they had a problem with getting the scan or something, which I didn't understand. And she said, "I'll call you back by the end of the day with an appointment." No call today. So my question with Dr. McHugh, I mean, I should be confident in placing my care in his hands. And you made a statement last week saying that well, we've had good results or poor results with Dr. McHugh. So now I'm really kind of thinking maybe I should move my care again.
Yeah, it's a tough one. I mean, it seems to me that since you got those results, you haven't heard from him, right?
Well, only with that initial consultation. And then he said, I'll call you back. I'll set up an MRI and I'll call you back once I have read the scan myself.
Right.
You know?
And you haven't heard from him.
No.
Well, you know, it does concern me, yes. And I think you should put that in the portal.
Okay.
You just put in the portal and say, you know, Dr. McHugh, it's now whatever it is, 2 weeks since I did that scan. You've had it. And I understand that I've got multiple metastases and I can't get hold of you.
Right.
Can you call me, please?
Right.
But you've got to put it in there, because once it's in there, and then that'll move them off the dime.
Right. That's why I went to the portal this morning, and she got back to me right away. But then
but you haven't heard from them.
Right.
And it's the end of the day. So you put it in. I tried to resolve it today. It didn't happen. So I'm just documenting this, and I need to talk to you. I need to know whether this is going to change my treatment.
Right. Exactly.
Right?
Okay.
But you have to write it down in there, because once it's there, it's in your medical record. And then they stop messing around with you.
Right. Right.
Right. So that's what I would do. As to whether to change Dr. McHugh or not, let's see what he does.
Okay.
Now, on the other hand, he's worked with some other people that we know, and they've been very, very happy with him. We got a guy with a BRCA mutation who's been very happy with him. And this is why I said to you, Dan, we've had good and we've had bad. The problem is it's very difficult to switch to another doctor at Memorial Sloan Kettering. I don't know how we would go ahead, Ben.
So what you do, they have on the website, they have a patient number, and you call them and you say you want to change your doctor and you explain why. It has not worked very well so far for Kang-Moo, but Kang-Moo has had a lot of things on his mind and has not been able to really push it. But they are set up to do that. It's not an impossibility. That's part of their function apparently, is to change a doctor if a patient feels uncomfortable. But you know, it has to be for cause. You have to be able to show them something.
Right.
I mean, I think we have to let it go a little bit further, but let's see. And, you know, if it continues, and then we can suggest other docs, for sure. But I think it's a little early. And I wasn't aware that they had this number. Ben, maybe you can let me know about that number, because this is something newer. We've had issues. So that's, but yeah, please stick on it and please document it. Really, really, really important.
I'll do that.
And, you know, speaking to somebody on the phone is not documenting it.
Right.
But when you
I'll put it in the portal.
Yeah, when you put it in the portal, then it's in your record. Then it's going to get some attention. And it's really thanks, Ben. Then it's really you'll see some movement, and hopefully by the time we come back in the next meeting, there is no meeting next week, guys, but on July the 6th will be the next meeting. You'll tell us something real positive.
Okay. hopefully I'll have some by then, and then I'll have something to report.
All right. And the other person I wanted to check in, because we don't see him that often anymore, is Herb Courtney, who I was seeing a very nice smiling face, and now I see a black screen. Are you there, Herb? You must have stepped away. I wanted to check in. I wanted to check in with him and see if he was okay. He's one of Dr. Rettig's patients. So. Okay, and Dr. Shellhammer dropped off, but hopefully he saw my post that Arches trial was for people who are hormone sensitive. The analysis was done on men who are hormone sensitive. So, so I will make sure, I'll send him a little note and just say that it was done on hormone sensitive guys. And that's the link to the trial, Ben, that I posted in the trial report. Sorry, that's the link to the trial report that I posted in there.
Yeah, I mean, my understanding is that this is not the Arches trial itself. This is a post analysis, an exploratory analysis that he's done on the data.
Yes.
Yeah.
Post analysis from the Arches population. Yeah. Okay, well, we had 20 guys who stuck with us, and all the rest had meetings. I've never seen so many people have meetings.
They're all partying together. They just didn't invite us.
All right, and nobody else comes into the room now because we can run over. So anything else? Has anybody got anything else they want to bring up before we close the room? Frank Chambro, what's going on? Have you heard from Dr. Young about whatever his name is about trials?
Tomorrow, 8 o'clock.
Tomorrow I go
Tomorrow
8
at
o'clock.
8 o'clock.
Yep, tomorrow.
I heard Lisa Glamorous. There she is.
That's Lisa Gorgeous.
Lisa Gorgeous. Lisa Gorgeous, Lisa Glamorous. It's all the same, right, Frank?
Yes, she is both of those.
Yeah. Well, please let me know. Those trials look kind of promising. And then I had somebody, here's Herb Courtney's come back. So we can talk to him for a second. But yeah, Frank, please let me know what he suggests.
Will do.
Eager to hear. Mr. Courtney, are you okay? How's life in Ventura, and how's Dr. Rettig, and what's going on? You're muted. You have to unmute.
There we go. Okay. Yeah, I just could join you for here a short time, but yeah, I just had another video with Rettig, and right after my blood test, and it was the same old. Our visit lasted about 5 minutes, and my PSA is still hanging in there at about 0.09, and all my blood works good. My testosterone's in the low 300s, but and that's just on daro. So
yeah,
good. Still working out.
You're one of our mono daro poster boys. You know that, don't you?
Can't complain. That's for sure. Yeah.
What was the PSA? Undetectable or?
It's 0.09. It's been 0.09 for I don't know, 6 months or so, but it's crept a little bit from all the way from 0.02 to 0.09. So, I'll be dead and gone by the time it's at 3.
Don't say that. Don't say that. All right. Well, So
Well,
always.
I just turned 89 the end of the month. So,
God bless
end
you.
of May. Yeah.
Whoa.
God bless you. God
Happy
bless you.
birthday.
Thank you. Thanks.
Happy birthday. Happy birthday. Okay, glad to see your face.
Thank you.
And Larry, in Alaska, what I can't make out what that question is asking.
I was actually composing an edition. I may be the editor of a newsletter that comes from the estradiol-initiative.organization.
Right.
And we're having a debate over what to call it. Some people want to call it the Estradiol Initiative newsletter. And the purpose is to acquaint men with the potential for this as an option for ADT.
Right.
But I think that name is kind of off-putting because people looking for ADT options are going to see estradiol and immediately go away. So my idea is prostate ribbon in nice blue letters that reminiscent of the ribbon awareness. Other people think things like a gentler ADT or anyhow, basically make it a binary question. If you see in a newsletter name the estradiol initiative or something that contains the word estradiol or something that contains the word prostate, which are you more likely to click through to?
Well, if for me, I think it probably should have something, it should be something related to what you're talking about, because otherwise people aren't going to follow through. So, and plus I'm always, if you read our newsletters, as you'll know, I'm a punny person. So, who was raised on a diet of the Marx Brothers, so I love puns. And so, you know, I might call it something like E to date. E to date. Something like, you know, it's not obvious. E numeral 2 and then date, or E2 something.
That's been proposed, E2 ADT or EADT. We want to, that's another question.
No, I'm not sure I'd put ADT in there because people don't know what ADT is. But I would say E2 letter or E to date. I like E to date. So, because it's got like, it's like up to date or E to date. And then, you know, the subtext would be something like, you know, all information about estradiol for men or something like that. Ben's better at this than I am. Ben, what do you think of E to date, and what could you suggest?
Yeah, I was thinking that E to date is very much in the spirit of Viaduct.
Yes, yes.
Not familiar with that movie.
It's from Coconuts. It's a line. It's not even a Groucho line. I think it's a Chico line from Coconuts. But go ahead.
Oh yeah. So the question is, who is going to be getting this newsletter? Who's your target?
Well, first off, the men who are actually on the signed up for getting notifications. We got about 100 going to the estradiol-initiative.org website. A number of them are using estradiol, and a number of them are interested, and some just curious. But we'd like to expand the number of men who are aware of estradiol as an option, because there's a lot of people who are not aware of it at all. So that's the target.
I mean, why does it matter what it's called, right? If you're going to send people, you're going to solicit people explaining what it is. So whatever you call the newsletter, they'll be interested in your selling proposition.
Well, we don't have all we've got is a mailing list of about 100 people. We want them to be able to find us, internet search, and not be put off by the name, but be curious about it and click in and read a little bit about. I don't know any other way to expand our readership.
Well, Ben will think about it. Anybody else got anything they want to contribute to Larry?
I do.
Go ahead, Thomas.
Well, okay, to feel like a complete idiot, but I don't care. I'm going to say it anyway. I would call it something like the estradiol option or the estradiol experience. Pretty simple, pretty straightforward. Bottom line is you've got another option. You're going to have this experience. So anyway, that's just my 2 cents. I'm sorry I had to victimize all of you with that.
No,
not at all.
okay.
Those sound good. And I got to apologize for the group. I keep missing the entry point on this forum because I always think of 4 o'clock my time, but it starts at 2 hours earlier than what I'm used to. So I came late. But thanks for your inputs. Rick, I'll send you a message with a better formed question.
No, it's okay. You don't have to. I'll stay out of it at this point. I have enough problem trying to keep us straight at AnCan. Never mind trying to keep Wassersoog straight. That is an impossible task. I leave that up to Dr. John. So
one other thing,
I'll stay out of it.
Yeah, Rick, the survey that I took, they sent me a check for $200. You get half of it for the foundation, the AnCan Foundation.
Thank you. All right, everybody. Look, Billy Ingersoll sang in to the very end, and Jimmy's gone. Oh, we're gonna like this guy Ingersoll. I can tell. He's gonna be one of us. All right. Close us out, Mr. Nathanson.
Yes. Good night to you all. Thanks for hanging in. Good to see
Bye.
you.
Good night. Good night, everybody.
Thanks, everyone.
Good night.
No meeting next week?
No meeting next week. Bye.